Hi, welcome everyone. My name is Lynette Martins. I'm here with Scott Schweikert, and we are back today to speak with Dr. Michael Steven about the changing terrain of healthcare on the front lines of this COVID-19 crisis. Before we begin, I would just like to take a small opportunity to congratulate the International Association of Bioethics under the leadership of Professor Ravitsky in conjunction with the Penn Medical Ethics and Health Policy Department, with Professors Moreno and Schmidt pulling off the amazing feat of hosting the World Congress of Bioethics this weekend, 3 years in the making, and having to pivot to a remote platform with unbelievable speakers with such short notice. And for anyone who was not able to view the conference, I believe the presentations will be up for the next 3 months. And I believe also you can continue to interact with presenters through the Q&A platform. I'd like to encourage you today to also type in your questions for Dr. Steven into the Q&A section. Your questions in prior webinars have been very thought-provoking and have enriched our discussion further. So please feel free to use that tool to communicate. Also, I'd like to briefly highlight that next week we're thrilled to have Professor Valerie Gutman-Cook, who will be speaking about medical provider liability. So if you are just joining us, welcome. We are getting ready to speak with Dr. Michael Steven, who's going to be talking about the changing healthcare on the front lines. Dr. Michael Steven graduated from the University of Pennsylvania Fellowship in Pulmonary and Critical Care Medicine in 2009. His biggest clinical and research interests have been in the area of cystic fibrosis, and he is the adult director of the Jefferson Cystic Fibrosis Program over at Jefferson in Philadelphia. He also attends in the medical intensive care unit and has been on the front lines of this COVID-19 epidemic in Philadelphia. So welcome, Dr. Stevens, and our thanks for being here.
Thanks so much, Lynette and Scott. And certainly this is a wonderful opportunity to speak. And it's very exciting to bridge the gap between, everything we're seeing in the hospital and some important voices that we need on the outside of the hospital. Thanks for that introduction. Just to give a little bit of the background, the problem is a virus, right? So this got reported, this new novel coronavirus got reported the end of December to the WHO, and probably been a problem in Wuhan, China throughout the month of December. Viruses have been with us for millions of years, for better or worse. 8% of our DNA is probably from leftover viruses. So we do have quite a bit of viral DNA. Some of it actually has some important functions. Most of it is probably just sitting there. Viruses have been described as sort of organisms on the edge of life, discovered in 1892 by a Russian botanist. And they infect humans, they infect animals, they infect bacteria, they infect plants. And they're just these little pieces of DNA or RNA that kind of float around and get passed from animal to animal. And they're very simple creatures. They cannot replicate on their own. They need human machinery or the machinery of an animal to replicate. So they're somewhere between life and not life. Little background on coronaviruses. These are traditionally animal viruses, and they likely all came from bats. And all of them, we think, came to us within the last 200 years. The first one was discovered, OC43, was in 1965 in Britain, the cause of the common cold, and probably came to us a couple hundred years ago from cows. Another one was, seen in the 1960s. The next one after these original two was 2002, which was the original SARS coronavirus. And this led to 8,000 infections and 800 deaths. So numbers much smaller, but a much higher mortality rate than SARS-CoV-2. Two more were discovered in 2004 and 2005. Middle Eastern respiratory virus was 2009 and had an extraordinarily high mortality rate of 34%. So these were the 8 coronaviruses seen before SARS-CoV-2. And of course, we know about SARS-CoV-2. And these are very, very recent introductions from the animal world to us. Some within the last 10 years, some within the last 10 months, but all within the last 200 years. Another problem is, the world is getting smaller. Extreme mobility, 430,000 people traveled from China to the United States in the month of January. And the atmosphere is something shared. Amazon rainforest depends on dust from the Sahara Desert, and Yosemite relies on nutrients from China's Gobi Desert. So the atmosphere is something shared, and we are moving around this planet like nothing before. Our world is interconnected. So getting into SARS-CoV-2 stands for Severe Acute Respiratory Syndrome, coronavirus number 2. COVID-19 is the disease. And we're in the lead here in the United States of almost 10 million cases. Throughout the world, we have 2.3 million with 373 million deaths per million here. And the whole West has in some ways failed. We have these extremely high rates, and if you look at Japan with 8 per million deaths and South Korea with 5 per million deaths, just an extraordinary difference. So Western Europe has failed, the United States has failed, and we've failed our country and our people, I feel like. And that's the pervading feeling in healthcare right now. But let's get into some of the lessons. So we can talk a little bit about pandemic preparedness. We're in a capitalist society. You cannot make a profit off being prepared, right? So that's something that we struggle with. What risk should we tolerate to be prepared for a disaster? 5%, 10%, 1%? In the second week of March in Pennsylvania, we could only run 5 or 6 tests per day for coronavirus using extremely old technology, which I'd never actually even heard of. It was so outdated. So it took us a while to ramp up for this crisis, and I think we paid the price. So it's a little bit of an unprecedented crisis in modern medicine. So that was my boss. Sorry about that. So modern medicine sort of began, in the 1950s, and we just haven't seen anything like this. So the fact that there were some hiccups and there was a huge learning curve for everybody involved is not totally surprising. There was a 2009 H1N1 crisis, but that was much smaller. Some schools had to be shut down, but we just haven't dealt with anything like this in the modern era. So first thing that came up is, it's not just a respiratory infection, and this is something we kind of learned on the fly. There's sort of evidence of total body inflammation, increased incidence of clots, very high levels of inflammatory markers. There's probably an encephalitis that's going on with this disease. So it's not just a respiratory disease, it's an autoimmune disease. And that's something, pretty unique too. That's not something that we see commonly with other viruses or even bacteria. So how to treat this? So this was a moving target within the hospital and within all hospitals. We did not have good studies, and the standard of care had also not been established. Certainly establishing standard of care can be very important. CDC guidelines, NIH recommendations, the Infectious Disease Society of America and CDC, they're kind of the forerunners, or have been the forerunners of setting the standard of care for the medical community in this disease and interpreting the data for us. Ultimately it's up to each hospital to decide, but if one hospital or 10 hospitals in the area are doing something, the chances of you not doing it are pretty low. So certainly there was a big rush to treatment. And the big story that you can look at was, standard of care in American hospitals in March and April was the use of hydroxychloroquine and azithromycin, and significant toxicity to both of those drugs. And kind of went against the old adage of only trust an outcome if it's been shown to be positive in 2 good trials. So both of these, hydroxychloroquine and chloroquine, they were touted as having antiviral and anti-inflammatory effects. The data allowing their use was a small French study of 26 patients with 6 excluded patients. It was not prospective. and they demonstrated viral clearing of 65% by day 5 in treatment and 19% in untreated patients. So huge, huge difference, but extraordinarily small study and not a prospective study. So the FDA, based on this French study and a few other small studies, issued an emergency use authorization in March 30th to allow COVID-19 patients to get hydroxychloroquine. And this became standard of care in the United States for every patient to get placed on 5 days of this drug with very poor data. And for several weeks at the height of the pandemic, thousands, if not tens of thousands of patients received this drug, hydroxychloroquine. Multiple sort of large observational studies have now come out that have shown no difference. The most recent one was published 5 days ago in the New England Journal by Dr. Galeras. And, an NIH press release said hydroxychloroquine studies say unlikely to help COVID patients. And that was, their study was stopped. Their randomized study was stopped after enrolling 470 out of 500 subjects. So prior to these observational studies coming out and this randomized trial coming out from the NIH, there were hints of toxicity. And so this hydroxychloroquine was abandoned about a month ago after 6 weeks of probably pretty intensive use. And then, this was a wake-up call to hospitals throughout the country, and especially here at Jefferson. It was that point, we got together as a division and as a department and basically said all unproven treatments should only be available through established studies. And these patients need to be randomized, putting, small studies out there and putting the burden of deciding what patients get what treatment based on poor studies on providers was extremely stressful. Do we put this patient on hydroxychloroquine? Do we give them, convalescent plasma? Am I withholding treatment here? Are they too sick? Are they too well? And now, so we sort of got halfway through the crisis, took a step back and said, okay, we're not doing this stuff anymore. We're not just throwing random medicines at people that we've been doing for 6 weeks, like everybody was doing. And we need to get these patients in studies, and that's the end of it. And so that was a huge relief to the medical community, I think. And this happened probably throughout the country, that we took a look. Hydroxychloroquine was a pretty big disaster, that was that. Looking at a couple of other medicines, tocilizumab, or if you're cool, you call it Toci. And this is kind of an interesting drug to look at. It's an anti-inflammatory medicine. So these COVID patients were showing up with total body inflammation. It's an extremely powerful medicine. So you give 1 dose and all your numbers look excellent very quickly. But as we know in medicine, that does not necessarily lead to better outcomes, sometimes worse. So you make your numbers look very good, but are you doing harm? It's a big immune suppressant. So this was another thing that was kind of thrown at doctors based on one small retrospective study from China of 21 patients that showed improvement. And so they said, okay, give everybody Toci. And we didn't really know what we were doing with it. Made our numbers look good. It made us feel better. But unfortunately, again, halfway through, we said no more Toci for anybody. They want to get in a tocilizumab study, they can do that. And the most recent trial from Italy, a good trial, 24 centers, 123 subjects, showed no survival benefit or entrance to the ICU in inpatients. So again, widely used based on a small study, and the bigger studies have shown no benefit. Remdesivir, an interesting drug. The initial Chinese trial actually showed the opposite, that it was not effective. But a New England Journal preliminary report in May of 2020, the ACCT trial of 1,000 patients from 68 sites, improved recovery time from 15 to 11 days. It was criticized for being ended early prior to mortality benefit shown. So some people said you should have continued the study to the end to see if there was a mortality benefit, but the decision came to end it early so that patients could get it. We could get it into the hospital soon. A lot of people suffering. Take it from there. And certainly you got a little bit of the Fauci effect, Tony Fauci gets in front of the country and says this is a good drug, well, good luck not doing it. The big thing in the news recently has been dexamethasone, cheap, readily available drug. This was a study out of Britain, gave a very simple 6 milligrams IV or oral in hospitalized patients. ICU has been wary of steroids over the years, it's shown very clearly to have an increased mortality in influenza patients, thought to due to increased viral replication from steroids. It's failed in diseases like sepsis, but COVID-19 is a different disease. So this is not a drug that we used widespread, but a press release showed good results from Oxford. A third deaths reduction on the ventilator and a fifth reduced deaths on patients on oxygen is a huge, huge result. But they haven't shown us the data. It has not been peer reviewed. So it has not been adopted yet widespread in hospitals. But certainly a very exciting trial. And this was a proper trial. It was not a small trial. It was a large number of patients and multi-center. Other therapies, lopinavir, ritonavir, has not been shown to be beneficial. Convalescent plasma studies are ongoing. It's a very old treatment. It's first used in 1891 and really hasn't changed since then. And we're looking for results of convalescent plasma trials. But if you look at each individual drug, basically the early studies, small, almost always contradicted the later studies, which were bigger and more appropriately done. So certainly big lesson there. Vaccine, we can talk about a vaccine. This is really going to help society dig out of its hole here. One interesting thing the NIH has done, it's put a lot of its eggs in one basket in Moderna to develop an mRNA vaccine. It would be the first mRNA vaccine in the world ever. So the wisdom of that has been debated as well. The nice thing potentially about mRNA vaccines is that they can be very effective in certain circumstances in animal data, and they can be made very cheaply and very quickly as opposed to other types of vaccines. So NIH has really gone all in on an mRNA vaccine, and some immunologists doubt the wisdom of that, but we shall see. Talking about spread, viral spread. So this was a huge source of stress in the hospital, not for doctors, but also, for the environmental cleanup people, for nurses, aides. This is not something that you want to take home to your family. Traditionally, there's thought to be sort of two modes of spread, droplet and droplet nuclei. Droplet are thought to survive only in large droplets. The rule is 6 feet. Certainly, if you cough or sneeze, that can go up to 28 feet. But things like influenza, and it's thought that coronavirus largely acts through this droplet spread mechanism, that these big droplets drop to the ground after 6 feet, and infectious particles clear the air in these large droplets. Droplet nuclei, or these droplets evaporate, but the organism persists in the air for a prolonged period. And that's things like tuberculosis and measles. And these subjects need negative pressure rooms, and masks are your standard 3M N95, as you can see in the upper right. And thank goodness this was not thought to be a droplet nuclei disease, because resources would have been under stress, times 10. It also exposed that we are not prepared for a large droplet nuclei disease. We just aren't. We weren't even prepared for a droplet disease, and that's just standard loop mask and no negative pressure isolation. So if it had been a droplet nuclei transmitted disease, that would have put the stress on PPE, times 10, and the stress on our rooms. There's supposed to be in negative pressure rooms with this droplet nuclei. This is stuff that just hangs out in the air for days. So thank goodness it was not that, but also gives you pause that we are not ready for a mass droplet nuclei disease in any respect. Talking a little bit about healthcare supplies, we had to get creative, right? So the standard before COVID-19 was to change your N95, your mask, your gown, after every single patient. And we just did not have the resources to do that. nor would I think it would ever be possible to have the resources to do that based on the number of patients we had. So to expect that you could throw out your mask with every single coronavirus patient you had, I don't think is realistic. And so we need more data on, how masks survive under what circumstances, cleaning mechanisms for them. If they get wet, are they still feasible? But certainly we abandoned the standard of mask after single patient very quickly. And, fortunately, I don't think we've seen a lot of bad side effects from it. So certainly we need to invest in PPE. What are we doing with PPE? How are we going to handle a droplet nuclei outbreak? Observations, talked about this a little bit. People did improvise with relative success, I think, in this country with the PPE. Ventilator use protocols went out from New York City, how to use one ventilator for 2 people, how to use it for 4 people. Talking about other things, a lot of information we received as physicians was sort of disseminated from other countries because they had been seeing this sooner. And there was a lot of things going on about vent versus no ventilator. Is putting somebody on a ventilator bad? What pressure should we be using on the ventilator? And this was a huge source of stress for me as I went into the hospital, because a lot of these opinions were questioning what we were doing. But it soon became very clear to me that I should throw all that stuff away, that all those opinions, use it for what it's worth, but you need to just stick to the basics, that you need to stick to what we know to do when. If somebody gets sick and needs a ventilator, you put them on it, you do not wait. Let's use basic pressures on the ventilator based on what we know about every other single infectious disease. Let's not throw everything out based on opinions from within the country and from abroad as well. So it came very quickly clear to me that a lot of what people were saying, physicians, a lot of them were physicians, it just did not make a lot of sense to me. Talk about a little bit of flexibility in the system, coordination of care. Sometimes hospital beds aren't the resource, it's physicians who know how to use ventilators. So large number of orthopods, nurse practitioners, and surgeons taking care of ventilated patients in New York City. And it's going to be very interesting to compare numbers from traditional medical ICUs to those ICUs being managed by non-ICU trained people. Other issues, medical liability. This was, you all can probably speak to this more than me. Seems like the system is broken as is. People are getting harmed who are not getting compensated, and people are getting compensated who have not been harmed. And it has not improved outcomes in this country. And certainly, medical liability laws were passed, and those are going to go through the courts, and there are going to be challenges to all of them, I'm sure. Certainly, moral injury, pervading sense of failure. Watching people drown is not fun. And post-COVID world, when we get there, pandemics are going to happen again. What are our expectations in terms of preparedness? Our statistics do not look good. We do not, and we are still not using modern technology in terms of tracing. Increasing numbers today, the death rate has continued to go down. Seems like a lot of younger people are getting infected in the South and the West. And, positive note, many good people worked very hard and certainly kept us from dipping into complete chaos. And I will speak to that myself. I myself came down with COVID, ended up in the hospital, and I certainly feel like I got the best care in the world from the best people there. And, it's not the people, it's not the workers, it's not the hospitals. These things need to be fixed on a much bigger level than me. Good. I think covered a lot there. Any single one of those subjects could be, a subject in an hour in and of itself. So we talked a little bit about the medicines, preparedness, and some of the bigger issues out there. So I wanted to stop there and take some questions.
Sure. Yeah, thank you so much, Dr. Stephen. Just the first question I have for you is, can you talk a little bit more about your personal experience treating patients with COVID and how doctors are dealing with that in terms of they don't want to take it home to their families? I mean, I've seen stories of doctors camping out in their cars or sleeping in the garage.
Yeah.
How do people balance that? How do you try to keep your family safe? And can you talk about your personal experience with that?
Yeah. Well, those are all very much personal decisions that each doctor made, and some isolated themselves. I heard stories of workers going into plants for a month, 6 weeks, and staying in there. Some doctors, came home and would shower every night and clean themselves up as best they could. And that was my approach, and it was not successful. So I got COVID, and my whole family got COVID. And there's, tremendous guilt on my part for having passed that along to them. Fortunately, everybody did very well, but certainly a huge sense of failure, both personally and for that happening. So certainly personal decision about what people were doing.
And also what's your take on there's been a lot of discussion about physician burnout in recent years. How do you think this whole pandemic is affecting just the burnout issue, dealing with these patients every day? Is it just the psychological factor?
Yeah. So, just taking care of patients who you have no answer for is very, very hard, and watching them go through their disease course without an intervention. Strangely enough, remdesivir has provided a lot of hope, and physicians are giving it and thinking they are actually making a difference now. So the results were not dramatic, but you never know how they're going to play out in clinical course. And physicians are telling me and that they really see very positive things. So that was a good thing to hear and to see when I came back from my illness. And so that's good to see. Numbers are falling. I don't know what other states, Pennsylvania, numbers are falling way down, and we're seeing other disease getting back to a sense of normalcy. But within the pandemic, 100% we'd see 30 patients a day, and every single one of them had COVID, and it was, very, very stressful. And but it's part of our landscape, and people are going to be able to deal with it differently at different levels. The emergency room physicians are certainly on the front lines. They cannot control their environment in any way. So I would say they're at pretty high risk for things like that. ICU physicians also at somewhat higher risk, although we can control our environment a little bit better. A lot of stress on the families. They couldn't come into the hospital. Most hospitals banned all visitors. People giving birth without husbands and passing away without relatives. So it was a society-wide thing that we need to come together. There was a lot of anger too, I think, that there's a sense of being let down, that there was more we could have and should have done.
We have a question here from Anthony Castroni, who is a critical care pulmonologist turned ethicist. So of particular interest, I suppose, to him. And his question is thoughts about unilateral DNR, even on an individual basis, and also your ECMO protocol.
Yeah, I'll take the easy one first, the ECMO protocol. So those were, ventilated patients who really weren't making it, very low oxygen levels despite maximal ventilation issues. They had to be well enough in terms of blood clotting issues to be able to undergo ECMO. Here in Philadelphia, everybody that we wanted to get on ECMO, we got on ECMO. It's a huge, huge resource, but we had an absolutely great team. Jefferson split everything up into things. So certain people were doing intubations, anesthesiologists, medical ICU doctors, taking care of the medical ICU patients, and then surgeons and a very specific ECMO team. So we had a great team. They set out very specific guidelines, which were very, very helpful. If your oxygen level is less than 80 in your blood and you're on maximal settings, call us. And if they're a candidate, we're going to put them on it. And they had very, very good results with ECMO. And that was a huge resource to have and as backup. Unilateral DNR is not something I'm super excited about. And not something that I think we did here at Jefferson. It did not become a level of stress on beds that we needed to confront that. It may have, in other places like New York City. And I'm not sure exactly what they did there. And it's not something I'm excited about, and something I think probably people you all know more about than me.
In Philadelphia, did you have the same situation? I guess in New York was really the hardest hit in terms of scarce resources. Did you have any issues of where you had to triage or?
We did not face crazy issues like that here. We were very full, and clearing the hospital out from other diseases was very helpful. And we had to make adjustments on PPE. We went into emergency mode for attending coverage too, right? It was all hands on deck. I started doing nights again for the first time in a long time. And so we broke up the schedule, all hands on deck, all fellows, and we were able to keep our head above water. There were adjustments in terms of PPE, but once the protocols got in place, who's taking care of what the schedule is, everybody pulled together, and we had good outcomes here. Certainly the system could have gotten overwhelmed, and then that's when you're talking about a lot of other stuff.
Right. I have another question here for you. Do you have any advice for members of the public who have postponed routine medical tests and procedures to avoid interacting with others and stay quarantined?
Interacting, okay. Somebody who wants to go get their tests done right now?
Yeah. Or just a routine test, not necessarily, they're postponing their regular medical care because they're afraid to go in.
Yeah. That's a city by city decision and a personal decision again. I think, numbers have dropped extraordinarily in Philadelphia, and I think things are very, very safe in the office. And institutions have overall done a very good job separating people, screening people. So if it's something important and things are under control in your city to a certain extent, and I would, by all means, take precautions, wear a mask, wash hands, and I would have every expectation that you're going to do well. Go ahead, sorry.
I was just going to say, yes, that's a sentiment I've heard elsewhere. Is like a lot of ERs were saying, please, we want people to still come in because they're worried about they're worried about what's going to happen if people don't come in. So, right.
Yeah, we have not seen a lot of spread in the hospital.
That's good.
Hospitals, I think, have been very, very lucky, and in that not happening, in different wards for COVID patients and different areas in the ER where they go. And certainly if the edge is off in your city, I would feel, that if you take appropriate precautions and are very careful, that you're going to do very, very well, and should not, that fear, I think, I don't want to say it's overblown, but I think it's something that we've learned to manage.
That's good. That's good.
One question about the treatments that are currently being used for your patient population. So right now, there's, remdesivir has kind of gotten a lot of attention. Dexamethasone is like being hailed as the next best thing.
Right.
Those of us who are not clinicians, or I suppose don't really understand the degree of nuance to the severity of which it needs to be used for. What can you tell us? Are we hopeful, or is there some use and benefit, and how do we sort of qualify that? Because I think a lot of people may be under the impression that this is an effective treatment and providing, this source of hope.
Yeah.
And in lieu of that, like if it really isn't, what hope do we have for such an effective treatment?
Good question. And, based on necessity, the trials are mostly being done in hospitalized sick patients. So for remdesivir, you need to be on oxygen or in the ICU for us to think that you're going to get any benefit from this. So if you're just hanging out at home with COVID symptoms, you should not expect to receive remdesivir, or that we probably don't think it's going to do much for you. It's only when you get in the hospital and reach a certain level of illness that you will get it. But it has provided a lot of hope for those people, and it's been an important lifeline, I think, for physicians and for patients. So I was a little taken aback when Dr. Fauci said, this is a huge day today. And I said, well, 14 days to 11 days, with no proven mortality benefit. But I think he's ended up being right on remdesivir for these patients on oxygen and in the ICU. Dexamethasone is a similar story, that there was no benefit seen unless you were on oxygen or in the ICU, and that they were very clear about that. So taking steroids at home if you have coronavirus, also not recommended. This is a hospital thing for patients quite sick. And so far, that's sort of where the data stands. And then the big thing that's going to get us out of the hole is a vaccine, and tremendous progress has been made on that, and hopeful that something effective will be found.
I have a question about the vaccine. I mean, I think Dr. Fauci said yesterday before the House that he was hopeful about a vaccine by the end of the year. I mean, do you think that's possible? Do you think there's a concern about pushing for a vaccine too quickly? What's your thoughts on that?
Yeah, that's a good question. I don't think there's harm in pushing it too quickly. A lot of these vaccines are able to speed up quicker because they have backbones already made for them from other vaccines. So there's like a meningitis vaccine backbone that's been proven to be safe. And so then they tag on some more proteins for it for coronavirus. So a lot of the machinery and a lot of the effectiveness and safety of these vaccine backbones is already in the lab. And so for them to just tag on something else to it speeds things up tremendously. So the technology is there at the biopharmaceutical level already for a lot of these vaccines.
Okay.
And so, I don't think it's going to be harmful. The problem is, how much does this virus mutate, and how effective are they going to be? So I don't think there's going to be harm in putting out a vaccine very quickly. And then, we just don't know about what this, viruses mutate every time it goes through a single person.
Mm-hmm.
So a virus will change with every single person. That's how you can sort of trace where everybody sort of came from. So there's signatures throughout the world to each of these viruses. And then hopefully it does not change too much. It does not integrate into the DNA like HIV. It stays peripheral to DNA, so that's also a very good thing.
Mm-hmm. Mm-hmm.
And what about, you mentioned the sort of, your hands are tied as a clinician on the front lines, that much of this should have fallen on the shoulders of somebody else, or perhaps someone in, an area of authority. Do you have any lessons, or I guess, who would you feel would be responsible for these instructions?
Yeah, I think, we got to get together as a medical community, and if there's a pandemic and bad things are happening, are we going to be issuing statements like the CDC said to use hydroxychloroquine based on small bad studies? So they issue a thing saying you can use this, and everybody jumped on it based on some small, very poor studies. And so we have to decide the balance of, is it worth potential side effects and stress and things for a medicine that we really don't know that works? Ironically, I presented 3 or 4 studies, and all of the smaller studies, the exact opposite was seen in the proper studies. So do we then go back and say to the medical community, we cannot freak out like we did, and it's not fair to providers, it's not fair to patients, and we have to maintain clinical equipoise here. And so I would think that that's a huge lesson that potentially all of us have learned if we decide to learn it, So.
How has this impacted some of your trainees, if at all? And I imagine this has had a huge impact on both how you train and how they are able to train. So I wonder if you could speak to that as well.
That's a great question. And so all students were suspended at Jefferson. So they got kicked out. They said, no, you're not coming into the hospitals. Do some homeschooling. You're not seeing any coronavirus patients. It's too risky. And they just came back this week, actually. But they are still not allowed to go into coronavirus patients' rooms. So starting from them and then working your way up, big discussions, interns, residents, fellows, what exposure should we tolerate in them? And ultimately, academic centers are reliant on these people, and they need to learn about this disease. So, it was made optional to go in the rooms. You can do a phone call to a patient and round that way, or look through the window. And I encourage that. These are younger people, and they're just getting started. And the older doctors, not too old, need to carry the burden. And I think that was kind of the pervasive theory, and in academic centers throughout America. The attendings, buck stops with them. And so if we need to, different rules. So conserve PPE and exposure risks. So, no physical exams on these patients. That's sort of medical legal issues there. But that was accepted, and certainly that's something I accepted in all my trainees. Certainly I can't imagine the stress that they were under. They're not in control of their own fate as it is. And then to have this strange disease be thrown at them while they're already under tremendous stress from training is incredible. But I think, looking back so far, everybody's did very well, pulled together, minimized their exposure. And then, fortunately, the few who did it actually ended up doing well.
Can you comment on, there's been a lot of discussion about the disparities in COVID-19, how it's playing out across America. Different populations of the country are being affected differently. Like the African-American population has been more harder hit. Have you seen that in Philadelphia? Just what's your take on that?
Yeah, it seemed like it was a disease that kind of started in rich people, travelers, hanging out, and then became shifted, and we shut everybody in their houses. So people with the bigger houses and places to get away, and people who didn't have to, go on public transportation to their job, they did much better. Once you lock people in a house, and if it's a small dwelling, that virus is going to spread if there's any chance of it. So we certainly saw that shift. It started out as one disease, and then it spread to another one. The working people, and some of those were doctors, not a lot, but certainly, service industry people, and people without the ability to control their environment. And so we saw that in a huge way here, and that wasn't fun to see. After a while, all we were seeing were people who had been locked up together, so it kind of stopped spreading in the community, but we were still seeing these after effects of people getting locked up, and somebody brought it home from work, and then
Right.
I think that raises kind of the question of, while we might be in a plateau right now, or maybe even a decline, if there are resurgences in COVID, how has this period of time really, has it been instructive, and what ways would you feel that the field is really prepared to handle now, given everything we've been through, and how effective the treatments that we have at our disposal would actually be?
Yeah, so that's good. That's a good question. Is a second wave coming to Philadelphia in the fall, and what's going to be different, and a lot of hope that a bunch of these other clinical trials are going to wrap up soon. So I'm very interested in the convalescent plasma trial. Be very interested to see the data from dexamethasone, and then you put that together with remdesivir, and then I think you really got something in terms of isolation, and people have gotten more comfortable knowing what to do and how to handle themselves, and so I think we're talking about Noel, myself and Noel, everybody has had a tremendous learning curve, and much more comfortable wearing masks and cleaning hands and a lot of it has become second nature. So I think we are much better prepared. We have some drugs. We have a lot of drug trials that show some hope. So I would be very, very hopeful. But you know, where's the next pandemic going to come from? And how is that going to be different? And are we going to be ready for that? It's going to be something slightly different. And then there's going to be a learning curve there. So
I have another question that came in. It says, for a while we were hearing that COVID-19 was affecting males more than females. Is that true, or what is the current thinking on gender differences?
Yeah, it does, you know, that seems to have borne out a little bit. You know, the pervading theory as to, you know, why this is men and why this is adults more than children. There's a term called nap COVID. So you'll have a 7-year-old, he'll get a fever to 102, he'll take a nap, and then that's it. Then he'll be done with the disease. So there's a nap COVID syndrome in these 6, 7, 8-year-olds. And the thought is they do not have this, what's called this ACE2 receptor on their respiratory epithelial cells. So the virus can really not get in there. So a lot of interest has been on this ACE2 receptor, differences between men and women, differences between young and old. And are we going to see that within ethnicities too, is an interesting thing. So it's not just about the underlying diseases, but people are really putting a lot of interest in this ACE2 receptor. I mean, we really have no idea about the immunology of this bug. It's a new bug. We don't know what's going on, inflammatory markers in the lung. So we don't know a whole lot about this disease. Some interest in the ACE2 receptor and underlying.
I think with all the uncertainty with both the sort of the immunology and how it, you know, what really is successful in counteracting it, you would think that this might inform policy moving forward. I wonder if you had any input on that. You know, and this might be a little bit out of the scope of this talk, but in terms of, you know, schools reopening, businesses reopening. I mean, I don't know if you have any input on that, just from seeing your patients and noticing, you know, what might be working and what might be good policy moving forward.
Yeah, I think, you know, Lynette, I think that's a great question. And, you know, nailing down the exact worst mode of transmission in this disease is going to be very important. People are really honing in on the respiratory portion, that maybe contact is not quite as important. So could that help us open up more safely? And, you know, at some point, you know, we do have to open up our society, obviously. And, you know, how best we do that is going to be difficult. I think moving forward in places with low transmission rates does certainly make sense to me.
I think that was the point you made between the droplet and the droplet nuclei, that if we're somewhat spared in that regard. So this might really truly inform not only this, but a potential droplet nuclei pandemic as well, which, you know, we've been thus far fortunate not to experience. Yeah.
We certainly need a plan for that.
All right, so I think that, I don't know if you have any final remarks, Dr. Stevens, leave us with a bit of hope.
No, you know, things, you know, we did get through it here in Philadelphia for a large part right now. And, you know, when you're in the middle of this, it feels like it's never going to end. There's no medicines and there's no hope. And we did that for about 2 months. But we have emerged out of it, and you can really see people's spirits rebound. And like I said, you know, great people in healthcare, and they want to do the right thing and work very hard. We just got to make sure they're supported.
Absolutely. And we want to thank you so much for not only sharing your wisdom and knowledge with us, but also for, you know, being on the front lines and looking after patients for, and being on the front lines, basically. So we're very grateful to you and to all the other frontline workers for everything that you do. And we'll close out by just reminding everyone that next week we'll be back with Professor Valerie Gutman-Cook. We'll be talking about medical provider liability, something Dr. Stephen might want to tune in for as
Yeah, I
well.
may want to, be back in the audience.
And to all the
Hopefully it
other
doesn't have relevance
and any of our JDMBEs who are tuning in as well, we know that this is something that has piqued your interest, and we are thrilled to have Dr. Cook providing her wealth of knowledge as she shares that with us.
I will give one shout. Can I give one shout out here, Lynette?
Absolutely.
Yeah, let me give a shout out. So yeah, I have a book coming out in January. What's the point of this if I can't get a plug in here? You know what I mean? So this is a book coming out called Breathtaking by Grove Atlantic. And, our post-COVID-19, it's going to be a lung-centric world out there. We know about the Holy Spirit, that's breath of life, prana, and many, many crises of the breath, COVID-19, climate change, wildfires. And, respiratory disease is something that we're going to have to take more seriously. And I talk a little bit about it in this book coming out in January.
That's terrific. And I think a lot of our listeners might be really interested in that. And this is going to be January 2021. Okay.
Yeah. Maybe I can come back. All right. I'll start plugging myself here. All right, everybody. You have a good day. Thanks again.
Thank you much again.
Thank you.
I'll see you next week.
Thank you.
Wednesday.
Yeah.
Bye. Thank you so much. Thank you.